Good day, everybody. Welcome to Dr. Tom's Tips Case of the Week. This week, our focus is on basically bread and butter, doing fillings with Isolite. Good morning, Dr. Hirsch. How are you?
Rolando, good morning. Hello, everybody. Thanks for tuning in today. Really interesting one today for you guys. I think you're going to love this and appreciate it because I'm going to show you some of the tips that I have developed over the years. Or they're actually out there. I didn't develop them at all, but they're out there just to really facilitate your dentistry and make things go really quick and really easy. I know oftentimes one of the most challenging things for somebody is getting mandibular anesthesia, waiting for that block to take effect. So first of all, today on a little class 2 filling, I'm going to show you how to obtain instant mandibular anesthesia right now. You give the injection and you go to work. There is absolutely no waiting whatsoever. So that's the first thing that we're going to carry on. That is done with intraosseous anesthesia. Now, with intraosseous anesthesia, you're injecting into the jawbone right between the roots of the teeth. So if you have the second molar and you've got the first molar right there, you've got to make sure that you've got a couple of millimeters of bone in between the roots of the teeth to be able to thread the needle in there. So I'm just going to go over this and talk to you as I'm actually doing it. So
Play it?
no, you can put it up, but don't play it.
Okay.
The first thing that I use,
Oh, sorry.
give me full screen here for a second.
Yeah, there you go.
What I use is something called the Tapedit Technique. It's available through Fairfax Dental. And these little blue tips are perforator tips right here that go right on the end of your slow speed handpiece, just like this. They lock in. And then if you pull the cap off right there, that's a little, I'm going to take that down low. That's a little perforator right there. It's not a syringe, but it's just a little beveled, looks like about a 27 gauge size needle that you will actually perforate into the jawbone. So that's one of the things that you're going to see me do. Before I do that perforation, I will put a drop of anesthetic into the papilla right there just to make them numb with a 30 gauge needle. That way they don't feel anything. The benefits of doing it this way are, A, you get to start immediately. You don't have to wait for any anesthetic. So from a productivity standpoint, it's phenomenal. The second benefit is for the patient, where all they feel is just the slightest little bit of tingling out on the lip. They don't have this profoundly numb lip, and their tongue is not numb. So literally by the end of the procedure, by the time they're walking out of the chair, the anesthetic is wearing off. So what that means is you got to choose procedures that aren't going to last longer than about 45 minutes, or you're going to have to go back in and renumb them. So what I do with this is I will take my anesthetic, put it in my syringe. This is the perforator needle that comes along with the perforator tip. So this needle on the left-hand side will be attached to your syringe, and that's going to go into the hole that you make with a perforator tip right like this. Is it challenging to do that? Absolutely. It's really difficult, and you really have to watch yourself and technique-wise when you're doing it. So it's make sure that you do this, and you kind of watch my technique as I do this to show you how it's done. So this needle goes on the end of your syringe, right like that. Twist it on. And then what I do is I take this off, is I will actually bend this needle over at about a 45, you can't see this, can you? There you go. I'll bend the needle over at a 45-degree angle so it makes it easier for me to feed into the perforation that I have just made. And then the other thing that you're going to see in the video is I will initially go in with some carbocaine, no epinephrine, and then we'll change this on the fly while this is in the patient's mouth to another anesthetic. So that being said, let's roll the video. I think you'll find this to be pretty interesting today.
Yeah, this is going to be awesome. All right,
Yeah,
you ready?
Here
we go. Here's our video, and
can you make the video on my screen bigger?
how's that?
There, yeah, not really, but it's good enough. So what I'm doing right now, stop that for a second. So the first thing that I did was with my anesthetic, I put a little 30 gauge, I put a drop of anesthetic into the papilla. And now what I've got right now is this handpiece with this perforator going in there. Now, usually we'll have water coming out of the handpiece, but the patient was so sensitive to the cold water coming out, she couldn't tolerate it. So we ended up having my assistant go in there with a syringe of warm water, a Monoject syringe. So go ahead, roll it. So you can see here with the Monoject syringe going in and out. The nice thing is she can concentrate what she's doing, and you can just kind of see the Isolite in the background vacuuming up all the water that she's doing. And you saw me taking that in and out. And then what I did is I fed the needle back into the perforation hole. And I got to apologize for the video. My assistant had a sore neck that day, so the stability of this was not good. Stop it right there. Pause that. Back up 10 seconds.
10 seconds. Okay, we'll go back 10.
There we go. So right there. So we're injecting, we deposited the carbocaine. I'll put about a half a carpule of carbocaine in there. And then on the fly, we'll go ahead and my assistant will remove that carpule while the needle's still in the patient's mouth. And then we take Marcaine, 1 to 200,000 epinephrine, and we'll put that in there. Inject the Marcaine in there. And you can see the little black hole where the perforation was. Right. Sometimes it will take a little astringent and block that off. Pause that for a second. I've got a couple of things to say. So when you inject the Marcaine, you want to inject it very slowly because the patient may have a reaction to the anesthetic, because this is going right into the bloodstream right now via the cancellous bone. And so if you have epinephrine in there, sometimes the patient will experience a tachycardia. Always tell your patients they may experience a little bit of an increased heart rate. It's not a heart attack, and that will calm down within about 30 seconds. So please be advised of that. The other thing that's really critically important is when you're making the perforation with the tip into the jawbone, make sure that you have lots of irrigation there. Otherwise, you'll burn the bone and you're going to get sloughing of the bone and the tissue there. So those are just some important factors. Oh, one more thing. When you're doing that, you will get anesthesia, 1 tooth posterior and 2 teeth anterior to the injection site. So on this particular one, let's say I was doing 3 occlusal fillings, or didn't matter what they would be, I could do the second molar, the first molar, and the second bicuspid all with that one injection. It's super.
Cool.
Yep. Okay, let's roll. So that's what we're going to do. We're doing a class 2 on tooth number 30. Camera shaking all over the place.
That's fine. That's fine.
Yeah.
You can see it evacuating.
Yeah. Oh, yeah. You can see the water getting evacuated. So now we're getting ready to go ahead and drill. And that's what happens when your photographer has a stiff neck. It's a little jerky and a little jerky and choppy. But we all know how to prep a class 2 filling. You go in there, you prep it, get it all cleaned up just like that. And you can fast forward through this if you want.
Yeah, it'll go through. Right?
Okay.
And you see the tongue. Oh, look at that. The patient's using her tongue to get rid of the fluid. That's cool.
The patient can move their tongue, whatever water's in there, the patient can do it. Pause it right there for a second. So right where the bite block is, one of the things I did not do is I didn't bring the patient's lip on the maxillary and mandibular lip over the bite block, so it could have pinched it a little bit right there. Always be careful of that. If you can point that out right at the commentary of the lip there and up above also. Yeah. So always make sure that I didn't do it here, but make sure that the bite block, that the lip is over the bite block area there. Okay, roll. And we get the whole thing prepped. As I said, this is just bread and butter dentistry, what we do all day long.
And it looks like your patient's really comfortable. Mouth's kept open.
They're extremely comfortable. And here's the other point. See the jerky camera, but here's the other point of this. Even with the Isolite in place, there's still plenty of room to get your matrix in, to get your wedge in, to get your separator in there. And doing class 2s are really tough. To do a really good class 2 and get a good contact is really tough. There's lots of different matrix systems out there. I think this one was by Triadet. I don't know which one it was, but they're all pretty much the same. And you can see the lip is getting pinched on the upper right-hand side. And we get the wedge on. You can see the matrix. Make sure you burnish your contact a little bit.
And as far as the patient is concerned, Dr. Hirsch, they're not tasting anything. It's all just, you've got your evacuation pretty full on, right? And
one thing that I can point out, pause it right there. Okay, so you can see right in the back, I could have chosen a different mouthpiece size because you can see the gap right back there, or I could have put a cotton roll or a gauze square back there. In this particular instance, it didn't matter because the patient was able to control that water with her tongue. So whatever went past that area, she just evacuated with her tongue. She moved the tongue around and got rid of it. But ideally, a different size mouthpiece would have been better there. But she had a small mouth, little opening. I just didn't want to stretch her out too much. And we wash it all out, and everything gets sucked up by the Isolite.
And you can see everything too. You've got that nice and
Yeah, believe it or not, I do use cotton rolls from time to time.
right on.
Yeah. There we go. We just turned the Cure Safe light on, so nothing sets. I think I used some Scotch Bond on this one. Dry it out, cure it. Took a little flowable into the box form way down deep. Yeah, there's my flowable going in.
And I notice again, you're the only one inside the mouth, so that just makes it easier.
Yeah, my assistant is just doing what she needs to do, and then we're just packing it. I said, once again, really jerky video this time. Sorry about that, gang.
Yeah. So from a productivity perspective, you can just kind of keep bumping along and not having to stop. I noticed too that your vacuum is on the whole time.
Yeah, I keep the vacuum going most of the time. It all depends how much water's in there. Sometimes I'll turn it down. The nice thing about this is that my controls for the vacuum are right there at the corner of the mouth, and I personally can fire it up a little more or turn it down a little less, or my assistant can. I mean, it's just everything's convenient. So it makes the productivity go fast. This whole procedure took me maybe, I don't know, 20, 30 minutes start to finish. I don't remember exactly how long it took. We should put a time bar down here so we can actually see our time is. We need to do that because we speed these things up a lot.
There you go. Look at that.
Take it off, take the matrix out. Try and take the matrix out. You got a good contact. Sometimes you can't get it out that way. You need a hemostat. And just pull it out and go in there, finish it off. Now, stop it right there. Stop right there. Okay, so here's the deal. I cannot get access from the lingual to finish down the buccal-facing inclined planes on the lingual surface. So I got to take the Isolite out to do that. Do what you got to do. So you'll watch me see the angle that I get, but I took it out and just to finish that off and adjust the occlusion.
There you go.
There we go.
But you can take it out, which is kind of
there's no rule. It says, hey, keep this thing in all the time. There's no rule at all. I mean, just do what you need to do to make it an easy procedure. And that's it. So I think that the tips of the day that you would get the most benefits from Tapedit. And there's different intraosseous anesthetics that you can use. There's the X tip, there's a Tapedit tip. But if you haven't done it, you should really try it. It will make life really easy. And it's really, there's just no stress when you know you're going to get mandibular anesthesia anytime. And I use this for crown preps, inlays, onlays. And the nice thing about doing it this way is if the patient, I get 45 minutes maximum anesthetic, I go back in there. If I got a longer procedure, I'll re-inject right through that same hole again. And that's just what I consider to be the best tip of the day is that one right there.
awesome. Thank you, Dr. Tom Hirsch. Really appreciate that. You know, I love watching the procedure because so often you don't really understand kind of what's going on. And I can see that, you know, patient definitely is a lot more comfortable and it looks like you're a lot more productive. So that is fantastic. So,
and remember, if you're going to do this, use water, slow speed revolutions, no more than 20,000 maximum revs, and lots of water. Don't burn the bone. Oh, and the other thing, one last thing. God, we're running late today. So one last thing on this. What do I tell the patients about me injecting into the bone? I don't. I just tell them, oh, this is just part of the numbing procedure. I'm not going to tell them I'm going to put a hole in their bone. I don't. If you want to do that, do that. For me, I just say this is all part of my numbing procedure. Right when I'm picking up that handpiece, I tell them, I'm not starting on your tooth yet. I'm just continuing with the anesthetic part. And I've never been questioned once on that. That's it.
Well, Thank you so much, Dr. Hirsch. Thank you. Those of you who like this, please share it. If you have any questions, please reach out to us. Let us know. If there are things that you'd like to see, please let us know. Thank you so much for Dr. Tom's tips. Looking forward to next week. Have a great, safe rest of your week, and we'll go from there.
And I don't know what we're going to do next week because I haven't videoed it yet.
Awesome. All right.
I'll find something interesting.
Awesome. Thank you, sir. Appreciate it.
Okay,
have a good one.
Thanks, everybody. Everybody have a great, safe day. Bye-bye.
Bye, guys.